This video covers a fractured forearm. The client is a 28-year-old student rugby player taking position at front row with the injury obtained during training after falling directly on the arm. Symptoms reported consisted of constant aching rated at 2 out of 10, sharp pain at movement of 4 to 5 out of 10, the ability to lift arm above 30-degree abduction and flexion. Being conscious of the 2 weeks in a sling after X-ray confirmation of a fracture, the examination of a client found rounded shoulder posture, poor elbow and wrist range of motion, reduced muscle power, and knowledge of a previous shoulder sprain on the same side. Therefore, the client got a final diagnosis of a fractured mid-shaft ulna. Due to this diagnosis, we are going to focus on the late stage of rehabilitation, highlighting the need for strength by prescribing forearm rotations. Here I am explaining to my client about the injury in hand, making sure there has been no further changes before explaining the exercise and gaining consent. Moving into the demonstration, I asked the client to maintain a neutral spine, keeping the elbow tucked in and to extend to full range of movement as much as they could. Forearm rotations are good in the final stages of rehab, as they can help determine the client's progressive strength for targeted muscles, whilst benefiting overall arm strength and health mobility. I explained that we are looking for controlled rotation directly from the forearm and not to use the shoulder joint as support, ideally with full use of pronation and supination. Whilst explaining that it's a prescription of 3 sets of 6 to 8 reps twice a week and weight increase once the 8th rep becomes comfortable, I was checking my client's pain levels and if we needed to progress. The amount of weight in the exercise is an important factor that adds crucial resistance and strain to the muscles and compression to the bone, which causes the exercise to focus on strength rather than range of movement. After realising this exercise was too easy for my client, I decided to progress and asked that we maintain the same exercise, but instead of holding the weight close, we extended the arm away from the body. This adds extra strain to the arm and also increases the work against gravity. With this progression, I changed the prescription to 6 reps with 4 sets. Lower sets and higher reps helps push for higher intensity and therefore an increase in strength endurance. Additionally, I demonstrated a regression for my client. Working against gravity can cause technical reduction, so I explained that if the resistance was an issue, to increase weight but use a stable surface to support the forearm. This allows the bone to still be loaded under movement, just without the addition of compression. After rewatching my videos, I would have ideally used a more suitable surface, a surface that was high enough for my client to maintain a natural posture and keep her elbow tucked into the side rather than her leaning forward. For the prescription of this exercise, I prescribed 2 sets of 10 reps, with the same principle of the 10th rep becoming too comfortable, the weight needs to increase. To overview my program for a fractured mid-shaft ulnar, I prescribed forearm rotations with 3 sets of 6 to 8 reps done twice per week, with progressions of holding the weight away from the body with 6 reps for 4 sets, and a regression of rested rotations for 2 sets of 10 reps.